countries. Today's lecture, Healthcare in Nepal, is going to feature two wonderful speakers. Yubraj from University of Michigan, who's been doing work in Nepal for a long time, and his work is on the barriers within the community, and his specific focus is on healthcare services in developing countries. Our second speaker is Linda Kaljee, who is a senior investigator with the Global Health Initiative here at Henry Ford, and she'll talk about her community health study in Nepal as well. So I want to get right into the two presentations. Please hold your questions for the end, and we'll have just about 10 minutes for questions right at the end. So, Yubraj.
Thank you, John. Thank you, everyone, for coming. Every grad student dreams of talking to a large crowd, in one of those stand-up comedies, except with the more boring stuff. And this is as good as it can get. And again, thanks. So what I'd like to do is just touch upon some of the recent trends, talk about a few challenges, and if you're interested, I could talk a little bit about the impact of the recent earthquakes, and also the status of medical education, since many of you are in the field. Over the last few years, in the last couple of decades, Nepal has made tremendous improvements in child and maternal mortality, and these are still high. So these are numbers from 1996 to 2011, infant and under 5 mortality. 46 deaths per 1,000 live births, still high, and I think this is what the U.S. had around the 1930s. But still, the trends have been remarkable. Also, fertility has declined significantly thanks to many factors, one of which is the rising use of contraceptives. It was 4.6% in 96, and now it's down to 2.6. And among many factors that have contributed to this, one is contraceptive use, delayed marriage. Girls are getting married much later than they used to. Also, temporary migration to countries abroad, particularly in the Middle East, and also reduced mortality. My mother had 8 children with an anticipation that some of them would not survive, and 3 of them didn't. The phenomenon that economists would like to call hoarding, and with the decline in mortality now, people are having fewer children. Also, service utilization is picking up. Here I've just put data on antenatal care and the number of births that were attended by a skilled birth attendant. It's also on the rise. And again, both demand and supply side factors have contributed to this improvement, particularly the role of female community health volunteers, which is a group of women, predominantly uneducated formally, and they were set up in 1989 as part of the vitamin E supplementation program, and their outreach efforts have been remarkable, and that's also the focus of my research later on. Sorry. In terms of the challenges, although the improvements have been remarkable, there are still significant disparities across geographic regions, income quintiles, education, gender, and ethnicity. The graph here, this is for ethnicity. The two groups, so the country has over 106 different ethnic groups, and the government has categorized them into 6 broader categories, and then categorized them further into 2, disadvantaged and advantaged, based on historical access to resources. The ones in the blue box, they are considered advantaged. The ones in the green box, disadvantaged. And you can see that there are significant differences there. Also, supply side constraints. Several of those. There's a shortage of qualified health workers in many rural areas, and also in many public facilities. And it's not uncommon to hear of cases where the physicians have diagnosed and operated on the wrong patient, on the wrong body part, that sort of thing. So the medical errors are quite high. And then of course, when physicians provide wrong prescriptions, those are often not recorded. And also, part of the reason why we have these absenteeism and deficit of qualified health workers has to do with the incentives. So if you end up using a lot of money when you go to grad school and even bachelor's level medical education, and so by the time you finish, you have so much loan that you have no incentive to work in the public sector because it doesn't pay enough. So in many cases, you end up diverting patients from public health facilities to your private practice. So there's shortage of drugs mostly in remote areas. It's very, very common. And also the infrastructure that weighs on, it acts as a barrier. Also because we don't have sufficient gatekeeping, some of these facilities tend to be overcrowded. If you have a minor health issue, very often you want to see the cardiologist or one of the specialists. And so that is also a problem. Also, the third challenge, I would say, is the shifting burden of diseases. In the country, in 2011, almost 45% children were stunted. And around the same time, a survey in urban areas found that 11% urban children were either obese or overweight. So there is this dual occurrence of nutritional deficiencies, and also some of the conditions that were some time ago thought to be more prevalent in developed countries are now prevalent in the country. Cardiovascular diseases, diabetes, and chronic respiratory problems, and mental disorder. And the mental disorder again has its root in the conflict and migration. For those of you who are not aware of the political scenario there, we've had a conflict from 1996 until 2006 that claimed more than 15,000 lives, and there was a communist group that wanted to do away with the monarchy and establish a republic, among other things. And also, if once you get sick, because there isn't a really good insurance program to speak of, the chances are that you will end up being very poor, and especially if one of the conditions that I mentioned before, you end up getting it. The government provides about 40 different drugs from local public health facilities, but free is not really free. And a recent tracking survey, this is actually a government figure, found out that almost 31% respondents paid for things that they were supposed to get for free from the local health services. So contract enforcement is a big problem. And also, there are cases where private hospitals force patients to keep deposits and force them to stay really long in the hospital, even if they are not required to, just to get the money. And again, it's very difficult to curb those unethical practices. And to summarize, in terms of if you're looking at it from the perspective of the patient, there are multiple barriers. And I understand that these barriers are not uncommon in many settings. What may be somewhat unique, though, is that there are certain groups that face all of these barriers. So if you're a Dalit woman in a remote district, then you probably face all of these. There are religious beliefs because of which you may not go to the hospital. Even if you do, the user fees are high. You might then be living too far from the hospital. And also, you might be treated differently by the healthcare providers, and you might not have an incentive to go. In terms of the policy response, the most recent document that drives the government's programs is the National Health Sector Program 3, 2015 to 2020. It's actually aimed at addressing all of the constraints that I mentioned before. it's quite ambitious with 9 outcomes, 29 outputs, and 126 measurement indicators. The problem, though, is implementation will remain challenging if the experience from the first 2 national health sector programs is to go by. As an aside, let me just talk briefly about the impact of the earthquakes in 2015. The overall damage and loss was 7 billion, which is about 1/3 of the GDP in 2014. The fiscal year there ends in July. In the health sector, it was 75 million, of which 61 million was in the public sector. So 19% of the facilities were located in the most affected districts. So the government has categorized the districts into most affected and less severely affected. And of that, 446 public health facilities were completely destroyed by the earthquakes. 18 health professionals lost their lives. Unfortunately, the reconstruction hasn't started because of political difficulties, mainly informing the National Reconstruction Authority, although the donors have already pledged the money that's required for reconstruction. Finally, I just want to talk about this. This is something that keeps me awake at night. I might as well put this on you. From 1996, there's been a rapid surge in the number of private schools for medical education. But the quality has been very poor. And so at the end of the programs, the Nepal Medical Council administers this certification exam. And in 2015, only about 49% passed the exam. And there is a significant conflict of interest here because many of the politicians, they have shares in these private hospitals. And in some ways, there is an incentive to provide them accreditation even if they don't meet all the required conditions that the Nepal Medical Council has set. And in almost all of the private hospitals, at least the ones that aspire to be teaching hospitals are in Kathmandu. The government commissioned a study to identify ways to reform the sector last year. And so the commission made a number of recommendations, including the fact that the government should not provide accreditation to private institutions in Kathmandu just because of the heavy concentration there. It also suggested placing a limit on fees and enrollment. As you can tell, these are second-best policies. If the market worked out itself, then these policies would not be necessary. But even then, the politicians have, in some ways, found a way to undermine these recommendations. A medical education commission was formed earlier this month. But then, one of the most controversial hospitals that is trying to be a teaching hospital, the commission said it should not be given the certification, and so in the parliament now there's a committee that's debating whether the hospital should get certification, and most of the people in the committee are actually shareholders in that hospital. That just gives us a sense of how difficult reform can be in this setting. So that's just a very quick overview of the the healthcare system in Nepal. I understand it's very brief and but hopefully that gives us sets the context for other presentations today. So what I'd like to talk about now is my research. For those of you who ended up coming later, I'm a doctoral student at the University of Michigan. I'm from Nepal, so I'm interested in understanding barriers to take up of healthcare services in developing countries, particularly for disadvantaged groups. So this was a study that I did in Nepal this summer. It was funded by 2 departments from the University of Michigan, and also the IRB approval was from University of Michigan and Nepal Health Research Council. Just want to mention that. Just to provide some background, so unequal access and uptake of healthcare services, it's a problem in all countries, irrespective of whether it's a developing country or a developed country. And outreach workers are often used to solve that problem for minority groups. But then majority groups are often overrepresented. I guess in the US, the landmark study that talked about that is the Sullivan Commission report from 2004, I believe. And also, there's a lot of literature in sociology that argues that network and friendship formation often takes place along ethnic lines. And because of that, if the majority health workers, if they reach out to their own groups mostly, then with the existing efforts, inequality could actually be worsened. However, matching every target beneficiary to an outreach worker based on ethnicity is often not possible, because any setting is likely to have this heterogeneous mix of ethnicities. Therefore, it's important to find a mechanism to reach out to minority groups by majority outreach workers. In Nepal, as I mentioned before, there are significant disparities in health access and outcomes. Advantaged groups, which are overrepresented in the workforce, they have better access and health outcomes. This is a graph that I showed before. And diabetes, which is the medical condition of interest here, it's rising. The current prevalence rate, this is from the International Diabetes Federation, it's about 4.5%. And this is probably an underestimate because a lot of it does not get diagnosed. Actually, in my sample, almost 10% are diabetic, which I believe is probably an overestimate because some of them might have eaten, but I'll talk about that in a bit. And so the female community health volunteers were the subject of this study. They're often cited as a key factor behind the strides in child and maternal mortality that I showed before. And they were created in 1989 to help administer a vitamin E supplementation program to children who are under 5. Right now there are 48,000 SVs working throughout the country. Again, all of them women, many of them, a significant portion of them without any formal education. So what I'd like to investigate is so what is the extent to which we can encourage outreach health workers from one ethnic group to another, and when we do that, what is the do the outreach health workers bring healthier patients instead of who they're supposed to bring? So if I'm incentivized to recruit somebody from a different ethnicity, do I go and recruit somebody from a different ethnicity even if that person has lower chances of having a health condition? And also from the side of the clients, if assuming that a health worker makes the same amount of effort, do clients from different ethnicities behave differently? So if a health worker is, let's say, African American, and I'm brown, do I behave differently than a client who is African American, even if the African American outreach worker makes the same amount of effort in terms of convincing me to go for a checkup? And can you also change that using financial incentives? I'll skip that theory part. The study also makes a theoretical contribution to what's known as the theory of discrimination. Goes back to 1960s work by Gary Baker. But that's not the focus of the presentation today, so I'll skip that. Just to explain the ACT setup, so this was a randomized control trial. We took 78 health volunteers from 8 village development committees. These are the lowest administrative units. Each village development committee has 9 wards. Each ward has 1 health volunteer. And so we divided them into 4 groups based on experience, education, and the broad ethnic category. And then we said, in arm 1, you will get rupees 20 per referral, irrespective of the ethnicity of the person you give the referral card to. So they were trained on basic, diabetes assessment, and then they were told, here are some referral cards. If you recruit if the person that you recruit shows up for the checkup on a pre-specified date and time, then you would get rupees 20 per person. In arm 2, we changed that. In arm 2, if you recruit somebody from a different ethnic group than your own, you get rupees 50 per referral. If you recruit somebody from your own, you get only 20. In arm 3, we reverse that again. If you recruit somebody from your own group, you get more. If you recruit somebody from a different group, you get less. And in arm 4, you get high amount, rupees 50 per referral, irrespective of the ethnicity of the person who is recruited. So the idea here is to mainly compare arm 1 to arm 2 and arm 3, and then also compare arm 1 to arm 4 to answer some of the research questions. Here again, an own type referral is defined as the health volunteer and the individual being from the same ethnic category. So if you're advantaged health volunteer, then and also the client is advantaged, then that's a one type referral. And they were given 50 referral cards, but they could call for more if they wanted, if they needed. And they were each given a day to recruit clients. On the side of the clients, they were also provided incentives. So they were given these letters that specified how much they would receive if they showed up to the health center for the checkup. The amount was between rupees 20 and 50 in intervals of rupees 10. So 20, 30, 40, 50. And again, we wanted to see if these incentives would offset the cross-ethnic barrier from the point of view of the client. And the health volunteers did not know the amount in each of the letters, but they were coded such that we, as researchers, knew what was mentioned. So for people who didn't show, we would know how much they were supposed to receive if they showed up. And when the clients came to the health center for the checkup, they brought both the referral card and the letter. Additional implementation details. So we held checkups in 8 health centers. This was from 7 to 10 a.m. Because the health centers open at 10 a.m. in the morning. We wanted to be done by 10. So on the day of the checkup, 8 practicing nurses, 20 interviews, and 3 research staff went to the health center. And in total, 2,403 clients showed up and had their sugar level tested. We tested the sugar level using the handheld glucometer that's commonly used. And those who had high sugar levels, they were advised to go for further diagnosis. And also, all the health volunteers and 97% of the clients who showed up, they were interviewed, which yielded a fairly rich data set if you want to look at mechanisms. And the referral card was such that it's possible to get some basic information on even individuals who did not show up. So it was like a boarding pass. One side, the health volunteer fills and gives it to the client. The other side, the health volunteer gives with herself. And then we've collected all the parts that the health volunteer kept with herself later on. And on that side, she would write the name of the person, she would write the contact number and the envelope number from that letter, so we would know what amount was mentioned in that letter. I wanted to do some follow-up study with people who did not show up, did not have time, but I have all that information in case I decided to do some qualitative follow-up afterwards. So in the analytic sample, there are 69. 3 of them did not show up to the training, health volunteers. The average age is 46 years, and they've been working for, on average, 19 years as a health volunteer. 28% of them have an education above grade 10, which is equivalent to the sophomore year, high school year. 62% are from the advantaged ethnic category. And on average, they visit 50 households per month. On the side of the client, 60% were women. Average is 52 years. And on average, they lived 27 minutes from the health center. This is just to show that the randomization worked. You can see that I put the p-values from the difference, sort of the orthogonality test for the 4 arms, and also p-values for the difference between arm 2 and arm 3, which are the critical arms. I'll take a minute to explain this one. So the first finding here is that health volunteers, recall that this is a setting where health volunteers are often known to actually reach out to other groups. Even in that setting, if you look at arm 1, so the table shows the mean number of referrals. So in arm 1, a health volunteer on average gave 24 cards to our own group and 16 to other group. So if I'm a health volunteer in arm 1, on average I recruited 24 people who belong to my own ethnic category and then 16 from the other group. Now in this one the incentive was the same irrespective of who you recruited. So this difference could be due to a range of factors. It could be that all my neighbors are from my own group. Right? It's hard to parse that out. However, now if we look at the number of own type referrals in arm 1 and arm 3, so the difference of 30.6 minus 24.29, 6.32, that's by how much you recruit your own type when you are encouraged to recruit your own type. If we compare the other type from arm 1 to arm 2, so this would be 19.06 minus 16.12. This is how much more you would recruit from the other type when you are encouraged to recruit the other type. If there is no discrimination, if I'm a completely benevolent health volunteer, then there should not be that any difference between those two differences. So irrespective of how much I'm paid to recruit my type or the other type, the response should be similar, but it is not. So if you look at, so I guess this is the second bullet there. If the difference in own type referral going from arm 1 to arm 3 is 6.32. The same difference for other type referral for the same amount of financial incentive, it's 2.9, almost 3. So almost half as responsive there. Although this is disturbing, on the brighter side, it also shows that with financial incentives you can encourage people, the health volunteers, to recruit the other type. So if you look at the difference in the number of the difference between other type and own type in arm 1, and compare that to the same difference in arm 2, the difference falls from 8.17 to a difference of 3. So by giving these differential incentives, we have encouraged the health volunteers to reach out to other ethnic groups. That's the takeaway here. The second key finding is, I'm almost going to be on time. The second finding is that very often there's a debate in the literature about whether higher incentives work. In some of these settings where there are gains to be had in terms of the reputation and prestige when you work as a health volunteer, there is some evidence that financial incentives could be counterproductive. So that might actually encourage me to work less if I'm getting paid, because community members know that I'm getting paid. I wanted to check that. If you look at arm 1 and arm 4, just comparing the differences, overall number of referrals are very similar, 40 and 39. But if you look at the difference between own type and other type, the difference goes from 8.17 to 18.7. So what this is doing, again, recall that arm 1 is when they're getting rupees 20 per referral, arm 4 is when they're receiving rupees 50 per referral. These are both undifferential in the sense that they get that amount irrespective of who they recruit. But when you give them a higher amount, the mix of ethnicity changes. So if I'm getting a higher amount, I tend to put more effort towards my own type. And this is not something that would be obvious if we were just to look at the overall effect. I have some theories on why this might be happening. So even in an area with ethnic heterogeneity, it's important to also look at how the mix of patients changes with higher incentives, not just the overall. This is just the confirmation of that. I was just looking at the timing of the referral. So the third thing I wanted to look at was, with these financial incentives, recall that in arm 2 and arm 3, we're encouraging them to recruit own type or the other type. When we do that, do they recruit people who are less sick? diabetic status, and also the sugar level to get at the extensive and the intensive margins. The coefficients are all stable, but they're not. It's a mixed evidence. I'm not clear what to make of this yet, and I could use some of your guidance. On the side of the clients, I didn't find any effect on whether the incentives were useful. My guess is that the incentives, even rupees 20 was already too high. In some of the health centers where you could get that sugar test, it would cost you around 70 rupees. And so by giving 20 rupees, I was essentially saying, you get that 70 rupees plus 20 rupees because the checkup was free. And that might have been already too high, which is why we didn't see any effect of the incentive here. Just to touch upon the limitations, it's a relatively small size. It's hard to look at hard to do subgroup analysis, and also I think the estimates here should be understood as a lower bound of the true effect that we would see in many settings, because the health volunteers here are known to reach out to other groups. To conclude, I think barriers due to ethnicity are can exist even in settings known for cross-ethnic cooperation, as I mentioned before. Differential incentives can be useful in reaching out to minority groups. However, higher undifferential incentives have the potential to be counterintuitive as far as addressing inequality is concerned. These are the conclusions that we could draw from this study in a somewhat unique setting, in a small sample. Thank you, and I'm sorry I took some of Linda's time.
Good afternoon. My name is Linda Kaljee. I work here at Henry Ford Health System, and my colleague who worked with me on this, Dr. Alfred Pak, works at the International Vaccine Institute, is a consultant there, which is located in Seoul, Korea. And just an acknowledgement that this was funded, it was through the Sabin Institute in Washington, D.C., but the funding itself came from the Bill and Melinda Gates Foundation. This is a small part of a much larger study of typhoid fever. It's called the Coalition Against Typhoid Fever. And it's an international group, and there's a lot of work being done both in terms of surveillance, prospective and retrospective surveillance of typhoid fever in Nepal, in Bangladesh, and in other areas, especially in South Asia, where typhoid fever, the level of disease burden of typhoid fever is very high. So this is just a small study in a much larger study. And this is a qualitative study looking at the burden that families experience with typhoid fever when a member of their household has typhoid fever. Let's see. Wrong way. There we go. I'm probably not going to go through all of this, but a short introduction to typhoid fever in Nepal, what the study objectives were, what methods we used. As I said, this is just a qualitative study. And I'm going to focus on the household case studies that we did. We also did interviews with health providers and with some of the female volunteers in a couple of the clinics. But just for time, because of time constraints, I'm going to focus on the household case studies. And then I also want to look a little bit at the impact of the earthquake on the use of healthcare and access to resources. By coincidence, we were in Nepal, we didn't know it, we were in Nepal at the same time. So I was there in August of last year as well. So there are about 21 million cases annually, with 90% of those cases occurring in Asia. Hospitalization occurs in 10 to 40% of cases, and complications of gastrointestinal bleeding and renal perforation occur in about 1 to 4% of cases. One of the primary issues with typhoid fever, as in many other diseases, is multi-drug resistance and the difficulty in providing care for people who experience typhoid fever. Typhoid fever is highly endemic in Nepal. Right now, they're in this process of conducting a surveillance, but there was a study a couple of years ago in 5 hospitals with 1,800 cases that were blood culture confirmed, and 70% of those are children under 15. So like elsewhere, typhoid fever is primarily a disease of children and infants. So everyone knows that typhoid fever is a result of contaminated food and water, so poor sanitation, contact with carriers, living near bodies of water, as well as climatic conditions, flooding and seasonal rain, which is a major problem in parts of Nepal, and socioeconomic context, overcrowding, literacy, affect rates of typhoid fever. I won't talk about, we already had an excellent introduction to the Nepali healthcare system. It's a pluralistic system, it's public, it's private, it includes biomedicine, Western traditional pharmaceuticals, traditional, spiritual, religious healers. So it's like in most of the world, health systems are very complex and include this larger system of the way in which people access care when they are sick. And of course, household use of different healthcare facilities is impacted by social and economic conditions within the household, disease perceptions, broader worldviews about, etiologies of disease, as well as, practical considerations, what's closest to me, and, who do I trust, who do my neighbors go to, who do my family members go to. So we wanted to look at, where do people go for healthcare utilization. This is a very biased study. We only talked to people who had blood culture positive, and so these were people who had been to a hospital. So this is not a community study in that sense. We wanted to find out what the burden was for people we knew who had experienced typhoid fever. A majority of people in Nepal are diagnosed clinically. They don't go for the blood test, and so this is just this very small sample. We wanted to look at family and community resources and networks to support households when they had someone experiencing typhoid in their household. We wanted to look at the social-economic burden through the duration of providing care and treatment for those patients. Assess the need for improvement in prevention, including health education, improved infrastructure, and vaccination. A large part of the Coalition Against Typhoid is focused on vaccination. They've used the polysaccharide typhoid vaccine in specific instances. They've had introduction studies, and it is still available for purchase. The conjugate vaccine is not available there at this time. And also to look at I just happened to be there, just a few months after the earthquake, and we all know that, of course, when there's a natural disaster, there's a major impact on the way in which people can access care. And so we just sort of added some questions to get a better sense of that. So it's qualitative. Most of the household interviews were in the people's household. A few people came to an office we were working at. They're individual, but if you've ever done household interviews, it's never individual because everybody in the household wants to have something to say. So individual in that we had one person as a majority respondent, but very often we had a couple. So if it's a child who had been sick, we had the mother and the father who were there, who were very actively involved in talking to us. We did some community mapping, or we had the people that we were talking to do some community mapping, and we just had this sort of like this outline of, this is where you live, and this is 1 kilometer, this is 5 kilometers, where are the pharmacies, which are the pharmacies that you use, where are the hospitals, etc. Just to sort of get a visual sense of, what resources were available. And then we did a very brief time and personal cost tool. And Yubraj is a health economist. This was not a cost of illness study, but we did just ask what were the indirect and direct costs. And we also asked how much time was spent. I haven't started analyzing the time component, but just, how long does it take you to get there? How much time did you have to take off from work, etc. So the data was collected the 14th through the 31st, on and off. They have a lot of strikes in Nepal. And so some days we went out and some days we didn't. So we had interview guides. Then we had this for our physicians, our community health workers, and obviously our household case studies. We had these forms with a mapping. Everything was audio taped, transcribed into Nepalese, and then translated into English. Data were entered into Ethnograph, which is a qualitative data management program. We developed a coding dictionary. Everything was coded. Then we used the codes to establish patterns and comparisons across respondents. The economic and demographic data were entered into Excel just for descriptive analysis. We identified people from local hospitals and medical centers. We were able to contact respondents, told them about the study, invited them to participate. And then, as I said, most of the interviews were conducted in homes, but a few were also conducted in an office. This is actually an interview with a health provider in one of the hospitals. So for our case studies, we had about half and half, male and female, a mean age of 32 years. The relationship to the patient, so 41% were the self and 41% were parent. Again, a number of the patients were young children, 4% spouse and 14% other. And then the age range for the patients were 2.5 years to 38 years. 68% were in urban, so this work was done in Kathmandu. We did go a little bit outside of Kathmandu, so sort of calling that a peri-urban area, and that was 32%. In terms of costs, it's no surprise. Those who were hospitalized, the cost was significantly greater, both indirect and direct costs. And one thing is that we had two people who were health providers who worked at a hospital who had insurance. Very rare occurrence, and so that's where the zero comes from. There actually were two people we interviewed who had no cost, but just an overview in terms of looking, and these are in U.S. dollars, and so total costs for hospitalized patients is something like $210, which is a great deal of money in Nepal. So first of all, we wanted to know, okay, what happened when the person was first sick? Did you what did you think was wrong with your child, or what did you think was wrong with yourself? And of course, most people didn't, immediately think I have typhoid fever or my child has typhoid fever. So people talked about seasonal fevers, common colds, that the child, was outside in the sun too long. And so, the initial treatment then was self-treatment. And of course, that's true in most cases. Unless somebody's violently ill, people don't usually rush to a medical center, especially when costs are high and access to the centers can be difficult. So, of course, the treatment was to treat fevers and aches. One person reported going to a pharmacy and receiving an antibiotic. We were a little surprised how few people reported use of antibiotics before they went to the provider. I'm not sure if that's I don't know whether they used them and didn't want to say they used them, or if they were using something and they didn't realize it's antibiotics. But in Nepal, as in most places in the world, antibiotics can just be bought like candy at the local pharmacy. And then only one person reported going to a traditional healer, and another reported using massage for a child patient who complained of stomach pain. A majority of people felt like, once they knew they had typhoid fever, they felt like this was serious, and their own experiences were serious in terms of the amount of time they had to spend recovering from the illness, the cost to them, and so overall, people perceive this as, something of, concern, and that it does create a great burden on both the patient and the household. A few people said that they didn't feel like it was so serious, and for one instance, this one male who said, well, I went to the hospital in time, and although I was sick, I wasn't that sick, and going to the hospital early on in the disease, he felt like prevented his disease from being more serious. So barriers, and some of these have already been mentioned. Obviously the cost is an issue. Some people talked about taking out loans either from their employers or from family members in order to cover the costs. The availability of adequate services and facilities, again, Yubraj talked a lot about this as an issue in Nepal, as it is in many, many places. And this was in Kathmandu, so for the most part there were some facilities not too far from where people were living. Obviously, once you're out into the rural areas, lack of services and facilities and transportation is more of an issue. Caregiving and social support. The families, of course, were the primary support for people. So it wasn't just the immediate family, but people had people coming in, sisters, mothers, daughters, husbands, brother's wife or something. So people were coming in and providing care. Only a few people said that they didn't require assistance. These were a couple of younger respondents who were actually out of their village. They were in Kathmandu, and they were, I think they were in school or, in a hostel, studying while they were studying. And also the gender issue came up. This was a physician who said that they felt like females were less likely or less able to seek out care, and that was a barrier for healthcare use in Nepal. Overall, the respondents said that they had changed their habits. Once they knew they had typhoid fever, that now they were boiling their water, hand washing, etc. However, some people said they hadn't really changed their habits, and about a quarter of respondents stated that, that they had made no changes. So we were sort of surprised that many people said, well, yeah, I had typhoid fever, but I'm still not doing anything different than I did before. Sources of information, of course, healthcare providers are key sources of information. There were, varying experiences going to the hospital. Some people felt like they were unsatisfied with the doctors and the treatment that they received. Other people had a great deal of trust and were very happy with what they heard, their experience in communication with the doctors. Of course, family and friends were sources of information. And only one person mentioned the media as a source of health information. So just a quick little few comments about the earthquake, which again, I won't go over this. Yubraj has already talked about the amount of damage that was done. We were in Kathmandu, which was not the epicenter of the earthquake, but there was still extensive damage there and a great deal of damage done to some of the health facilities. Some of what's interesting is, of course, we realize there are always these direct effects, because hospitals are destroyed, because health workers are injured or killed, because of transportation, that people have less access to health care after an earthquake. But one thing is the psychological trauma people talked about affected their ability. So they might have been able to go, but they were fearful to go. And so they were concerned that there would be, and of course it wasn't just one earthquake. They had, hundreds of aftershocks and pretty major aftershocks. And so people were very fearful to go anywhere, to leave home. Of course, destruction of home and property made their lives much more difficult anyway. Many people, even if their homes weren't destroyed, people were living outside because they were afraid to live in their homes. Another thing is dual care for caring for injured and those who were sick. And so we went to a couple of households who had within their family, people had been seriously injured during the earthquake. And therefore they were already caring for the person who was injured. One person, they were still spending a lot of time at the hospital because they were helping to care for a niece. And then, of course, the added burden of caring for somebody who was sick with typhoid fever. The lack of infrastructure, again, that's fairly standard, that it was, they didn't have water, and concerns about being outside and lack of sanitation. Loss of work, obviously, so less money. People, were unable to get to work. They had to close their shop. Banks were closed, so we talked to one person whose child was sick, but the banks were closed, so she couldn't get, even if she had money, she did have money in the bank, she couldn't get it. And then the association of typhoid fever with earthquake. So a lot of people, when their children were sick, within, or when someone in the household was sick, within, this period of, such total disruption, they said, they thought it might be because they were having to live outside, that they were in the sun, that it had to do with psychological stress. And so their first thoughts were not something along the lines of typhoid fever or infectious disease, but rather that the cause of the symptoms had to do with their current living conditions and, again, the psychological stress. So typhoid fever remains a significant health issue in Nepal. Initial symptoms of typhoid fever are, of course, similar to many other illnesses, which can lead to delay in treatment. Testing facilities are lacking. Again, very few people get blood culture, and so the clinical diagnosis is used, which also contributes to misuse of antibiotics, use of antibiotics in instances where perhaps someone does not have typhoid fever or other bacterial infection. Hospitalization, the economic burden when a person does need to be hospitalized. The ongoing need for prevention messaging, the number of people who, despite the fact that they had had an experience with typhoid fever, were still not changing their household routine in terms of boiling water, etc. The potential role for vaccination programs as a part of prevention, and the importance of recognizing the complex direct and indirect effects of major disaster on health-seeking behaviors. And this is a beautiful picture of Nepal. I never saw Nepal like that because it was the rainy season when I was there.